Hello?
Yes, ma'am.
Yeah, okay. So we're almost at 200 students. If any problem occurs, please let me know, okay? Because I had a lot of problem last time when I took the class. So today's topic is otosclerosis, and it is also known as otospongiosis. But there's a difference between otosclerosis and otospongiosis. It can be divided into active and inactive phase. The active phase is known as otospongiosis, okay, and inactive phase is otosclerosis. Before we start off, we have to recapitulate some of the anatomy of the inner ear. So I guess you all know the anatomy of the inner ear. There's a membranous labyrinth, there's a bony labyrinth. The membranous labyrinth is filled up with a fluid known as endolymph, and the bony labyrinth and the membranous labyrinth has also a space in between which is filled up with a fluid known as perilymph. I guess you do remember, don't you? You do? And the otic capsule, the bony labyrinth, has 3 layers. I'm just recapitulating, okay? And those 3 layers are endosteal layer, the innermost layer, the endochondrial layer that develops from the cartilage, ossifies to bone, and these cartilage which remains unossified, then they gives rise to new bone formation leading to otosclerosis, and the periosteal layer which covers the bony labyrinth. Now, if you look at the otic capsule or the bony labyrinth embryology, you see that there are 14 centers of ossifications. The first ossification occurs in the cochlea in 16th week, whereas the last, it occurs in the posterior lateral part of the posterior semicircular canal, which is in the end of 20th week. So this is just a little information about the embryology. Now we come to the topic, that is otosclerosis. Okay, so this is a primary disease of the bony labyrinth. This is the disease of the inner ear. Okay, and you see there are 1 or more foci of irregularly laid spongy bones, okay, present, which do not get ossified, like we talked about earlier. So these bones, these cartilage which do not get ossified, they are replaced by, new bone formation, which replaced part of the normally dense endochondrial layer. That is what it means. And it mostly affects the stapes region, okay? There are various areas around the stapes, which we will discuss later. But the stapes is the main area where this occurs. So what happens when there's a new bone formation around the stapes footplate, it should move, isn't it? If you look at the normal physiology, but once there's a new bone formation, then the stapes gets fixed. Once the stapes get fixed, then the sound does not travel, and this can lead to conductive deafness. And it can also involve the bony labyrinth too, and this can lead to sensory neural hearing loss. So now the definition, you need to know the definition properly. They might even give you a question, define otosclerosis. Then you have to give this definition. This is a localized hereditary localized disorder affecting the endochondrial bone of the otic capsule. This is the disease of the otic capsule that is characterized by disordered reabsorption and deposition of the bone. And otosclerotic lesion, it consists of an area of bone reabsorption, new bone formation, vascular proliferation, and a connective tissue stroma. So this is the definition, and there is a definition in your book too, but this definition is taken from Scott Brown. Now we look at the etiology, the cause. The exact cause is not known, but there are various postulated theories. Some of them tells us that this is due to the anatomical basis. So as we discussed, there are cartilage rest in the endochondral bone, and they get activated to form new spongy bone. And the area of focus where these happen is in front of the oval window, that is known as fistula antifenestrum. This is the name. So this means this is in front of the oval window, that is in front of the stapes foot plate. And if you look at the hereditary predisposition, there 50% have positive family history, and it is an autosomal dominant disease. So you might get in MCQs, otosclerosis is it autosomal dominant or recessive, or then you have to know this is an autosomal dominant. Race, if you look at the race, you see even in our context, India and Nepal, we do see, but they are lesser in Japanese and Chinese, and even it's common in black people too. Look at the sex gender distribution. You see it's more in female gender than male. 2:1 is the ratio. And if you look at the onset, you see the patient coming to the OPD are mostly between 20 to 30 years, but they do not come in the younger age, okay, or even later. So these are young people with the complaining of conductive hearing loss. And if you look into their eardrum, you wouldn't see much of change unless and until they're in their active phase, then you would see that red hue. Otherwise, the drum looks totally normal. The other factors are especially in females, it gets worse in pregnancy and even after menopause. This is due to the hormone changes that occurs. And it can be associated with some other disease like osteogenesis imperfecta. This is a genetic disorder which affects the bone, and where there's a multiple fracture of the bones because the bone is brittle, okay, diseased. And the syndrome, which is known as Van der Hoof syndrome, is a triad of osteogenesis imperfecta, otosclerosis, and the patient will have a blue sclera. So these three things makes and syndrome, that is Van der Hoof syndrome. So this can also come in your MCQs. Now, if you look at the types, so there's a stapedial otosclerosis. This is a very common type which you see in the OPD now and then. What happens here? There's a stapes fixation, and due to that, the patient would come, young patient with conductive deafness. And this type of otosclerotic foci are seen anterior to the stapes foot plate, which is also known as fistula antifenestrum, that is the anterior focus. There can be posterior focus behind the oval window. There can be a focus around the margin of the foot plate, which is also known as circumferential. As you can see in the picture, this is from your book, so you can correlate. And foot plate with the free annular ligament, which is a biscuit type, as you can see, gives a shape of a biscuit. And there can be another focus, which is known as obliterative. There's an obliteration of the oval window niche. So they're all covered with this foci. So this is one type. The second would be cochlear otosclerosis. Here, the round window and the other areas of the otic capsule gets where you find the focus. And this one would lead to sensory neural hearing loss due to the liberation of the toxin into the inner fluid. And there is another type, mixed 2, which has both cochlear and stapedial. I think mixed is not given in your book, but it is in the other books, the standard other books. And there's a histological otosclerosis too, histologic. These remain asymptomatic. You wouldn't know it would not give rise to conductive or sensory neural hearing loss, but this can only be seen when you do a cadaveric dissection. These are only seen then, so it does not give rise to any symptom. Now, if you look at the pathology, so macroscopic and microscopic features. So if you look with your naked eyes, what would you see? You would see a chalky white patch, which is of grayish or yellow in color. Sometimes you would find it even reddish. This is due to the increased vascularity. Like I told you, the process is in an active stage. So, and this is also known as otosclerosis. Due to the increased vascularity, you get that reddish color. But microscopically, if you look under the microscope, you would see a spongy bone in the endochondral layer. There's an immature active lesion. That means numerous marrow and vascular space with plenty of osteoblasts and osteoclasts are seen. They can be stained blue if you stain it. And in a mature stage, if you look, you would see less vascularity, more bone, and it's fibrillar substance, and it stains red. Okay, so you can get either in an active stage or an inactive stage. So depending on that, you would see these features. Now, looking at the clinical features, the patient would come with a complaint of hearing loss. Okay, there's no history of pain, but the hearing is increasing with the time. It's progressive conductive hearing loss. In your in your exam, sometimes you might get PBQs, problem-based question. If there's a question telling you a young person with a progressive conductive hearing loss, that means otosclerosis has to come to your mind. Okay, young patient with progressive hearing loss bilaterally, starting in the early 20s. So that should give you a clue. It might be otosclerosis. And if the drum is normal, that is another more, points in favor. And there's a term called paraacusis Willis. What does it mean? It means the patient hears better in noisy environment. There's nothing so special about it. It is because what happens in a noisy environment, people tend to talk louder than in a quiet environment. Because of that, the patient hears better. Okay, so there's no other mechanism. So the term is paraacusis Willis. Tinnitus, okay, you get it in an active disease and in a cochlear lesions. Speech will be monotonous, well modulated, soft, and vertigo is uncommon. When you look into the drum with an otoscope, what do you see? If the patient is in an inactive phase, both the ear tympanic membrane would look normal. But if you see a patient who are in an active phase, then you would see a SWOT sign. So this is another MCQ's question that you might get. SWOT sign. What is that? You would see a reddish hue over the promontory. As you can see, the arrows are showing, and the eustachian tube would be normal functioning. And if you do a hearing test, okay, with an auto tuning fork, you would get Rini negative, okay, and the normal ABC test, but decreased bone conduction in case of cochlear otosclerosis. But the common presenting cases would be conductive hearing loss. So the patient would get Rini negative mostly. Now there's a typical, characteristic feature of a pure tone audiogram in case of otosclerosis, which is known as Carhart notch. This is another important question for MCQs. So Carhart notch is seen in which disease? So you should know it's seen in otosclerosis. So what is a Carhart notch? You can see it in the picture. Okay, can you see the dip in 2000 Hz? Can you see it? So this notch is Carhart notch. So what happens here? The resonance frequency of the middle ear for air conduction stimulation is around 800 to 1200 hertz. So you have to keep that in mind. Okay. So resonance frequency for bone conduction is about 1600 to 1700 hertz. So these are the standard measures. Any bone conduction disorder that decreases the mobility of the ossicular chain, okay, that is 16 to 1700 hertz frequency range is affected most prominently. Okay, so what happens? 2000 hertz is the closest frequency tested in a typical hearing threshold measurement. Because of that, you would see the dip in 2000 hertz. So we do not measure in our audiogram in 16 to 17 hertz. We measure 125, 250, 500, 1000, 2000. So the resonance frequency of bone conduction lies near to 2000 hertz, and because of that, and we are measuring at 2000, so you would see a dip here. So this is why the dip occurs. So Carhart notch is important. Okay, one characteristic, even in your let's say spotting, there might be a pure tone audiogram with this Carhart notch, and they can ask you, write down your diagnosis, okay, and other questions related with it. So this is an important. Now, if you do an tympanometry, you would get an AS type of curve. Mind it, these things will again be explained to you in your audiology classes. That will happen at the end of your otology classes. And the speech audiometry, if you do, then you would get a normal discrimination scores. So these are all going to be explained. Previously, we used to, take audiology class before, but we thought we changed it because theories are not taught, so you would not understand earlier. Once the theories are over, so towards the end, the audiology will explain again these diseases along with the audiology. Now, the differential diagnosis. What are the differential diagnoses of otosclerosis? People get confused. So you have to keep all these things in mind. So sometimes even OME, otitis media with effusion, may just look like your otosclerosis. Another is adhesive otitis media, tympanosclerosis, attic fixation of the head of the malleus, that you can get it. Ossicular discontinuity, congenital stapes fixation can also be there. So these are the differential diagnoses. These congenital stapes fixation, attic fixation of the head of the malleus, these are all, seen when you do a tympanotomy, when you lift up the tympanic membrane, look into the middle ear, and then only you can diagnose it. Otherwise it would give you a similar picture like otosclerosis. So you have to explain it to the patient that once we open up, once we look into the middle ear, then if it's something else, we would not be putting the Teflon piston and doing the full surgery. We might have to close it and leave it as it is. So these are the differential diagnoses. Now look at the treatment. There are 3 types of treatment that you can do. One is medical, another is surgical, and number 3 is people who do not want to undergo surgery. They can wear hearing aids and it works well. Now the medical treatment, even if you do medical treatment, it does not cure otosclerosis. What it does is it only hastens the maturity of the active foci and it arrests further cochlear loss. So what is the drug that you give? That is sodium fluoride. So sodium fluoride can be given in the daily dose of 50 milligram. Okay, it can be given for 2 years and can be increased up to 75 milligram in a very active stage. But looking at the side effects caused by the fluoride, these are not in practice these days. We do not use it. And this can be a though this is in the book, so you have to write it when you get this question. It can be treated medically, surgically, and hearing aid are the three options. But the drug is this, and we do not use these drugs at present. Surgical treatments, there are various surgeries. One is stapedectomy, another is stapedotomy, and the third is neostapedotomy. Okay, so what is stapedectomy? That means you have to remove part of the stapes footplate. Stapedotomy means you make a hole, okay, you drill a hole. There are fine burrs that is used for this surgery. So you make a hole in the stapes footplate, and neostapedotomy is a new surgery these days. Here you do not cut the so what tendon is attached to the stapes neck? Can anyone tell me? Just anatomy. Huh? Does anyone know? Nobody knows? Okay. Now, there are various types of pistons, prosthesis, okay? These are made up of different materials. So, commonly used are Teflon pistons. You can even get stainless steel pistons. There are platinum pistons. There are titanium Teflon pistons. So, there are various, and they are expensive according to the make. So, you can use any of them, but the very common one used are Teflon pistons. Now, when do you do any stapes surgery? When there is a airborne conduction gap of more than 50 decibels, when the Rini is negative with 250 and 512 Hz tuning fork test, and when the speech discrimination is more than 60%. So these are the indication. Now, what are the contraindication? Contraindication, again, poor speech discrimination. Only hearing ear, if it's associated with Meniere's disease, very young children, professionals like athletes, okay, who work in constructions, drivers, so you have to, air travelers, frequent air travelers, so you have to be, careful if you decide to do even. Workers in a noisy environment, otitis externa, if any infection, tympanic membrane perforation, exostosis, pregnancy, because they are in an active phase, and sometimes second site surgery. You have to make sure, because there are various complications, and you might even sometimes give the patient a dead ear too. So you have to be careful. Now, if you look at the stapes surgery, it's similar to myringoplasty. There are approaches where you can do endoral approach, you can do post-oral approach. These days, endoscopes are there, so you can even do endoscopic. Okay, so what you do is, after it can be done under local as well as under general anesthesia. But the advantage of doing this surgery under local is, once you connect the incus with the stapes footplate, then you can test the hearing immediately on the table, okay? But if the patient is under general anesthesia, you wouldn't know whether the piston is working or not, that you have added and connected to the stapes footplate. Then once the tympanomeatal flap is elevated, raised, and reflected, then you would see the posterior superior bony area where there can be bony overhang. The bony overhang has to be removed until you see the stapes footplate and the stapes suprastructure clearly. And once you see, then all the middle ear structures, once it is seen, then what do? Then you have to dislocate the incus from the stapes head, and sapedial tendon needs to be cut, but this tendon is preserved in neostapedotomy. That is what I was trying to tell you. So you prevent that. These days they do not even cut this, but in the previous surgery, They used to cut, they used to dislocate the incus lenticular process from that of the stapes head, and the Tiflin suprastructure is removed. You make a hole, or if you are doing a dectomy, then you remove a part of the stapes foot plate. If not, you drill a hole. People even put a vein graft on top of it. There's a measuring rod. You have to measure the distance between the incus long process and the stapes foot plate, and then you have to clamp the Teflon piston on the long process of the incus, and then below to the stapes foot plate. And then there's a ossicular mobility. The vibration will be transmitted, and you can just test it on the table, and the patient will start hearing. But what are the complications? If the surgery does not succeed, patient will still have conductive hearing loss. Sometimes, if there's a perilymphatic fistula or any trauma, then they can even have a dead ear. Okay, complete sensorineural hearing loss. You can even injury the facial nerve, which is nearby. Patient can get vertigo. They can be chorda tympani is there. So if you cut it, they can get taste alteration, loss of taste on one side of the tongue, and sometimes infection can go travel in, and intracranial complication like meningitis can happen. So these are the various complications that you come across. And people who do not want to undergo surgery, the hearing aid is another treatment you can give. A simple hearing aid. You can even give bone anchored hearing aid, and even cochlear implant can be done. So this is the third option for the patient. So you have to write when they say treatment, you do not write stapedectomy and that's it. You have to write it in a elaborated form like medical, surgical, and hearing aid. You may not need to write the steps of surgery, but the surgery that can be done are Panera, stapedectomy, stapetotomy, and neostepedotomy. There are various methods you can do. You can even use a laser. You can even, these days endoscopic stapedectomy can also be done. So you can add up all that too. These are the new methods. So I guess this is all. Though it's a very short chapter, it is important. You would get questions in PBQs. You might get questions in your short notes, and you might even get questions in your MCQs. So please go and read this chapter.